Good evening, everyone. I'm here for a case presentation, and the session would be moderated by Dr. MPB ma'am. So, a 58-year-old female presented to us with the complaints of redness in both eyes for past 6 months, diminution of vision in the left eye for past 3 months, and hearing abnormal noises in the head for past 3 months. History of presenting illness. There was gradual onset, progressive, painless, diffuse congestion in both the eyes for past 6 months. Initially, according to the patient, redness was present in the right eye, but gradually involved the left eye as well. There was painless, progressive diminution of vision in left eye for the past 3 months following a surgery. Past ocular history, both eyes were diagnosed elsewhere as primary angle closure glaucoma. The left eye underwent phacoemulsification plus IOL implantation and trabeculectomy on September 22nd, and again underwent a retrabeculectomy in November. There was no history of any ocular trauma, and when patient presented to us, she was currently on both the eyes anti-glaucoma medications, precisely brinzolamide, brimonidine, timolol, and nitazoxanide. Medical history, she was a known hypertensive and asthmatic. On examination, the right eye visual acuity was 624, improving to 618, whereas left eye was 2 by 60. On slit lamp examination, right eye had corkscrew vessels, shallow anterior chamber, no NVI. Left eye also had corkscrew vessels, a flat conjunctival bleb, and a patent surgical PI. On gonioscopy, right eye had occludable angles, and in left eye, there was 360-degree synachial angle closure. On applanation tonometry, the intraocular pressure was 12 and 15 mmHg, respectively. These are the slit lamp images of the right eye. You can see some conjunctival corkscrew vessels, and in the left eye, more prominent conjunctival corkscrew vessels in almost all the quadrants, and a patent surgical PI and a shallow anterior chamber. So the patient underwent YAG PI in the right eye in view of occludable angles. A suspicion of left eye malignant glaucoma was made because the patient had undergone two glaucoma filtering surgery and had a shallow anterior chamber. So UBM was advised, and a retina and oculoplasty opinion was asked for. When the patient presented to us in retina clinic, these are the optos images of the right eye. One can see some mid-peripheral retinal hemorrhages. Then in the left eye, there were multiple retinal hemorrhages along with disc hyperemia and choroidal mounds seen in almost all the quadrants. These are again the optos images of the left eye. So a suspicion of both eye decompression retinopathy was made because the patient had undergone glaucoma filtering surgery, and maybe iatrogenic rapid decrease in intraocular pressure might have led to these both eye retinal hemorrhages. And also a suspicion of vein occlusion was made, right eye non-ischemic and left eye ischemic. So investigations were asked for. These were MRI, brain and orbit, and USG was advised. So this is the USG image of the right eye showing a normal attached retina. And this is the left eye USG images. One can see here choroidal detachment and an attached retina. The OCT image of the right eye showed a normal foveal contour, whereas in the left eye, in the left eye, one can see a macular edema. Thickening was there. Now the UBM images, one can see here in the green arrow, these are the anteriorly rotated ciliary body causing a anterior shift of the iris IOL diaphragm.
Yeah. Yeah, what is the frequency of the probe in this case?
Uh, 35.
That's what I said, read the image. No, that is, I said, read the image. Okay. Okay, 35 megahertz probe. Yeah, tell me just read the image.
Ma'am, this is UBM of left eye showing the angle and the structures posterior to the iris. This one is the angle.
Is the angle open or closed?
Uh,
Anyone? Is the angle open or closed? What is that?
just a scleral spur.
That's the peripheral roll of iris. Okay. Okay. Then after that, what else you see? Where are the ciliary processes?
The pars plicata.
Where are the ciliary processes? Are they visible? Are they not visible? If they're not visible, why are they not visible? Yeah, Ayushi?
Not visible because ciliary body is there is anterior shift of the ciliary body.
Okay, what else is there?
This is the iris,
Mm.
the cornea,
Mm.
ciliary body,
Mm.
the sclera,
Mm. And
and
what is the
the
abnormality?
choroid.
Uh,
Um,
what is the abnormality?
the ciliary body is anteriorly shift,
Mm.
and there is space between in the
What
suprachoroidal
is that space called? What is that
um,
space due to?
effusion,
Yeah, ciliocoroidal
ciliary
effusion.
body effusion.
Okay, yeah. And if you look at the transverse scan, what do you see? You see
Um,
that ciliary processes are blunted.
yes,
Okay,
ma'am.
you see they're blunted and round. Yeah, proceed.
UBM left eye confirms supraciliary effusion. Patient was started on left eye topical steroids and hometropin drops. Anti-glaucoma Ripasidil was stopped in the left eye, whereas Simrenza, that is brinzolamide plus Bimondin combination, was asked to be continued. Patient was planned to start on oral steroids, and physician clearance was asked for, but still the MRI reports were awaited. And these are the MRI images of the brain and orbit. You can see here, these are the coronal sections where one can see these enlarged extraocular muscle, sorry, where one can see here the enlarged extraocular muscles in the left eye as well as in the right eye, but some fibrotic changes in the right eye. One can also see here in this axial scan that there is enlarged extraocular muscles.
Swati, would you like to comment on the MRI?
Hi, good evening, everybody.
Dr. Swati
Um,
is an interventional radiologist and it's very kind of her to join us. Welcome.
right. No problem, it's my pleasure. Now, here in this view, we are only seeing these green arrows which show enlargement of the extraocular muscles. The other thing what we have to observe is at the level of the cavernous sinuses that there may be some extra blood vessels we see in cavernous sinus region, which indirectly suggests keratoconus fistula. Third thing, when we are searching for keratoconus fistula, we look for if there is enlarged superior ophthalmic vein. But in this patient, um, I'm not able to exactly see that enlarged superior ophthalmic vein.
That red, ma'am, that red arrow I have marked in the
Would
coronal.
be, huh? Yeah, yeah. No, when I'm enlarging it on phone, no, it is getting little blurred, but I think it is there. Some
Yes,
small thing might be there. That superior ophthalmic vein. So these are the three things what we see in indirect keratoconus fistula on two things. That whether there is any extra vasculature in the cavernous sinus region, and is there any dilatation of the superior ophthalmic vein. That is the important thing. So that indicates that there may be presence of keratoconus fistula.
so, as told by ma'am, there was this enlarged bilateral extraocular muscles with fibrotic changes in the right extraocular muscles and pointed red arrow. This is the dilated left superior ophthalmic vein. And also, prominent flow voids were seen in the left posterior cavernous sinus. The scans are not with us here. And based on these MRI findings, a suspicion of left cavernous fistula was made. So now the dilemma that left eye macular edema, is it secondary to CRVO or is it secondary to CCF? So at this point, the anti-VEGFs were deferred and cerebral angiogram was advised. So this is the cerebral angiogram image. It is type D CCF. Type D means the dural branches of both the internal as well as the external carotid artery are anastomosing with the cavernous sinus. So the major here, the right internal carotid artery dilatation as well as fistulas can be seen. You can see here also that there is evidence of this dural arteriovenous malformation of the left cavernous sinus. And as I just told, that the arterial supplies by the dural branches of bilateral internal carotid artery, mainly by the right internal carotid, also partly by the left internal carotid artery as well. And
Left internal, left internal maxillary artery.
sorry, ma'am, left internal maxillary artery as well. You can see here.
Dr. Swati, would you like to educate us on this image?
Sure, sure. Can you go to the previous image, doctor? Yeah, thanks. Basically, let me first tell you that when we do angiogram for keratoconus fistula, what we want to do is that we want to see the angioarchitecture of the fistula so that we can divide it into subtypes of type A, B, C, and D. So, is everybody familiar with these types, or do you want me to tell them? Okay, type A means it's a real caroticocavernous fistula. That is, there is no malformation in between, and internal carotid artery ruptures, opens up in the cavernous segment and opens into the cavernous sinus, and the cavernous sinus drains blood into different directions. So that is type A fistula. But after that, type B, C, D, calling them fistula is a misnomer because they are actually dural arteriovenous malformations of cavernous sinus region. So the dura over the cavernous sinus region harbors these arteriovenous malformations, and this BCD comes because of the arterial supply. It comes from where? Like for example, for type B fistula malformations, the dural arterial supply comes only from bilateral or unilateral internal carotid arteries. The external carotid artery does not take part into this at all. But when we go to type C, it is internal carotid arteries don't take part at all. It is only external carotid artery branches, their dural branches take care to supply this dural AVM. And when we go to type D, D for Delhi, which is the commonest type, where internal and external carotid artery branches usually take make formation of this dural arteriovenous malformation. So what we do is that we do bilateral internal carotid artery separate angiogram, bilateral external carotid, and especially in bilateral internal maxillary arteries, because they are the ones which supply usually the caroticocavernous fistulas. So this is how we do. It is called a six vessel angiogram because bilateral vertebral arteries also just for this thing we check. Now, what we see into this is that it is not only the arterial supply, we have to see the venous drainage because patient's symptoms and signs and how do we manage also depends quite a large amount on where is the venous drainage. Like, for example, in this patient, though she has all the eye symptoms, there is no venous drainage in anterior direction. You are not seeing dilated superior ophthalmic vein on angiogram. In fact, if you see in this first picture, first slide, second picture, you can see right. I see a lateral view. Posterior to the artery, you can see that there is some blood going. So basically, there is blood going in the posterior direction and not anterior direction. Can you please go to the next slide? Similarly, in the left internal carotid artery, also you can see that posterior to the left internal carotid artery, one small this thing is going, small venous thing is channel is going. So again, here the venous drainage is in posterior direction. In internal maxillary artery, you can see here, Dr. Yamin, if you can show by your pointer, I don't have pointer here. Miss, I can't use my pointer. That there is a small dural arteriovenous malformation and which is again running into posterior direction. So actually, this patient should have more this thing of tinnitus or something like this symptoms rather than proptosis chemosis. But she does have proptosis and chemosis also, but no anterior venous drainage. Now here, this patient, most important thing is that she does not have cortical venous reflux. Whatever the venous blood is there, it is running not back into the blood. If it runs back into the brain, then that is a dangerous situation because that patient can have intracranial hemorrhages because of venous hypertension. But here there is no cortical venous reflux. It is extremely slow flow fistula or so slow flow malformation. So it is not too dangerous for the patient as far as the brain is concerned. So that is what is my input on this patient.
Thank you, ma'am. So, based on the cerebral angiogram findings, patient was advised both sides intermittent manual carotid compression at least 5 times a day for 12 weeks, and intravitreal anti-VEGF was deferred in left eye at this point. Anti-glaucoma medications were stopped. Topical steroids were asked to be continued.
Just a minute, may I interrupt here? This is too less a number of compressions. This should be 5 times in 1 hour, like that, at least for 6 7 hours he has to do. Unless they do 35 to 40 times in a day, it will not be effective. Just by doing 5 times a day is not sufficient for producing the progressive thrombosis of the fistula.
Anti-VEGF was deferred at this point. Anti-glaucoma medications were also stopped. Topical steroids were to be continued. But the question was whether to give oral steroids or not. So the choroidal detachment was actually non-inflammatory, secondary to back pressure from the CCF. So therefore, at this point, we had withheld the oral steroids. Patient was advised to have a local IOP checkup after 1 week and then every 2 weeks. And risk of superior ophthalmic vein thrombosis, worsening of vision was explained. And she was advised to be under close follow-up. The effect of carotid compression in helping to reduce the choroidal attachments was to be evaluated in the next visit. So the patient presented to us after 15 days. And when she presented, the vision was almost the same. In the right eye, 618, and left eye, counting finger 2 meters. Pressures were 12 and 10 mmHg. Um, Open angles, AC was formed in the right eye, and left eye had formed AC with no bleed or and no leak, and had a flat bib. And gonoscopy, right eye was open, and left eye, as earlier, 360-degree synachial closure was there. But in the fundus, left eye had retinal hemorrhages with macular edema, but with resolved choroidal detachment. I don't have an Optos image, but I have the USG, the left eye showing an attached retina and resolved choroidal detachment. So there was no CDs at this point. So at this point, left eye intravitreal anti-VEGF was planned because it was thought that the vision has not yet improved and macular edema was still persistent, and there was a resolved choroidal detachment. So maybe the vision decrease might be secondary to the CRVO component, and hence the intravitreal anti-VEGF was planned, and the patient is yet to be under subsequent visits for us.
Ratni, would you like to discuss this case? Because I think you have seen in the glaucoma clinic.
Yes, ma'am. So to begin with, this patient might have been one of in the spectrum of primary angle closure disease, probably. But since she gives history of redness for 6 months, so that has complicated the picture, and also that the fact that she's had the trabeculectomies, and she's had two trabs one after another. All this congestion and all would have probably caused a failure of the trab, so probably they planned and did a re-trabeculectomy. The other thing about this is that these cases are with raised episcleral venous pressure, and owing to the CCF, they are at high risk of uveal effusion and expulsive hemorrhage. So usually, while performing surgeries on them, we combine it with a prophylactic sclerotomy. So in this case, we don't know if because of the trabeculectomy she had the effusion and the choroidal detachments, or as a complication of the surgery, or probably because of the CCF itself causing raised venous pressure and hence congestion and detachment. So overall, the all these factors have complicated the case more. But I think she did well after this intermittent carotid massage, ma'am. So, and then after that, I think the series have completely resolved. But since that anterior chamber was shallow and for a very long time, now she's having complete synachial closure. So we expect the pressures to probably go up. And the other eye maybe was just a primary angle closure. So that's why that I also needed medications for IOP control. And
Anyone has any questions for Ratni? Jaiprakash, you also handled the case.
The dilemma for me was whether to give anti-VEGF or not, because there was a caudal detachment, and planning an anti with a caudal little tricky, and also whether the macular edema is due to a vascular occlusion or was it because of the back pressure from the CCF. So that was also a dilemma. So the choroidals have reduced, and now anti-VEGF is planned because the macular edema is still persisting.
with the decompression retinopathy, is it possible to have macular edema, ma'am?
No, not usually.
Mm.
The only thing was sometimes, usually decompression retinopathy, the vessel caliber and all looks okay. You just have those
Mm.
round hemorrhages, whereas this
S-
a bit like a full-blown CRVO.
Stereo.
But then, post-trab for us, first diagnosis
Differential, yes, ma'am.
differential would be, and the other eye also had some hemorrhages. So that was probably one of the reasons why it was considered as a differential. But I think that slit lamp finding of corkscrew vessels is what prompted the look for the low flow CCF.
Yes, 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 ma'am.
Can go to the next case. We have one more case somewhat similar.
So, a similar case of a 64 years old female which presented to us with complaints of painless congestion and diminution of vision in the right eye for the past 8 months. The redness was in both eyes initially, but as per the patient, it settled down in the left eye. There was history of headache since past 2 weeks, but no history of any vomiting, tinnitus, no history of any ocular trauma, fever, or any unusual systemic event. These are the slit arm images. You can see again here in the right eye, there is presence of corkscrew vessels. The optos images, the right eye, you can see here a choroidal mound nasally. The right eye USG again shows the serous choroidal detachment. And the left eye had a attached retina and a normal architecture. On gonioscopy, the right eye had occludable angles, but there was no blood in the Schlemm canal. The patient had pigmented TM. Now, in MRI, brain and orbit reported that there was bilateral enlarged extraocular muscle, empty cella, right choroidal effusion, but no superior ophthalmic vein dilatation, and also no abnormal flow in the cavernous sinus. But based on the clinical findings, that is presence of these corkscrew vessels, choroidal detachments, and occludable angles, also enlarged extraocular muscle and choroidal diffusion, all these prompted us to again think of a low flow CCF. So cerebral angiogram was again advised. And these are the cerebral angiogram images. It is actually a type B CCF, that is type B caroticocavernous fistula on the right side. That means that the dural branches supplying the malformation are from the internal carotid, basically the right internal carotid, which is actually not identifiable in these angiogram images.
Swati, you would like to comment because I think you have managed this patient also.
Yeah, actually, this patient had a indirect suggestion of malformation. That means on the internal carotid angiogram on the right side, what we are seeing is a early draining vein. So, as such, malformation is seen little, and the early draining vein is seen. But even on digital subtraction angiogram, I'm not able to see any feeders as such there. So they must be really minuscule feeders, and the vein is draining into anterior direction, but I am not able to see superior ophthalmic vein dilated. Luckily, neither there was a cortical venous reflux or something like that. So this is extremely low flow type B caroticocavernous fistula. And because there is no cortical venous reflux, it becomes again safe to manage the patient, at least give a trial of 2 to 3 weeks for intermittent carotid compression massage, because as it is giving endovascular treatment in this patient also will not be easy or easily possible, because you are not seeing anything to go anywhere, neither the arterial branches are seen, neither this vein is seen draining anywhere, so you really don't know where to dig and do embolization. So for this patient, the only option remaining was to do intermittent manual carotid compression, and luckily it was safe because no cortical venous reflux. There was no other vessel which was supplying this malformation, or this vein was not getting opacified in any other picture. That's all from my side.
Thank you,
But I
ma'am.
don't know her follow up. She never came back to me, if I'm not wrong.
Show you the pictures.
Okay.
So, on cerebral angiogram, type B carotid cavernous fistula was diagnosed, and patient was advised to do intermittent manual carotid compression on the right side. On 1 month follow up, the right eye had open angles with intraocular pressure of 16 mmHg in both the eyes, and symptomatically, the redness had improved. These are the optos images. Again, the right eye, the previous choroidal mound, which was there nasally, has disappeared now. So the choroidal detachment has resolved. And also initially, as you remember, the right eye had occludable angles, but now the angles have now opened up and the intraocular pressure is also normal. So at this point, no glaucoma intervention was advised, and patient was advised to be under close follow-up and also under the follow-up of a neurologist as well. So
Anthony, you would like to give us some clues about how we suspect that it may not be a primary occludable angle in these patients. This one has a very gross choroidal detachment, but anything else we see on gonioscopy which should tell us maybe it's due to a CCF?
Yes, ma'am. Clinically, slit lamp examination look for the dilated episcleral corkscrewing of the vessels, and usually it will be unilateral. So, if at all the patient is presenting with a secondary angle closure, the other eye invariably may be open, but that also you cannot be sure, because those with angle closure have a they have a more chance of choroidal expansion, and also it might have been a pre-existing angle closure. But most of the times it's a unilateral presentation with a with a red eye because of the dilated vessels, and there's blood in Schlem's canal. And in if usually they present as secondary ocular hypertension. Uh, this secondary angle closure is not so common. So and this angle closure, there is no role for a YAG PI, ma'am. And usually around at least 70% just resolve both the open angles and the angle closures resolve with just massage or any endovascular interventions. So high index of suspicion, ma'am, usually in a unilateral case.
One more suggestion I would give: when we are suspecting a CCF and someone does an ultrasound, please look for the extraocular muscles, because traditionally we used to report that as well. And if you see enlarged extraocular muscles, diffuse enlargement of extraocular muscles in a patient with a red eye, with these corkscrew vessels, then your diagnosis of a dural, what used to be taught was a dural fistula, is more likely, because this patient has already undergone a course of steroids and was sent with suspicion of a choroidal malignancy, because it was felt that those were sentinel vessels. So that is also a differential diagnosis, which was the original presenting diagnosis with which the patient came. Please proceed.
So, just a word about glaucoma and CCF, as ma'am has just now discussed. The main contributory factors for glaucoma in CCF patients are usually the suprachoroidal effusion and raised episcleral venous pressure, which is because of CCF. So, can be associated with narrow angles. You should always rule out a coexistent angle closure. So, you should examine the other eye. So, if you can remember in our first case, the right eye had undergone YAC PI, and ma'am just now told that PI has no indication in CCF patient, but that patient was diagnosed as a primary angle closure glaucoma. So, always examine the other eye, rule out coexistent angle closure. And the cause of shallow anterior chambers and occludable angles can be basically anteriorly rotated ciliary body along with the suprachoroidal effusion. So both of these will cause a push in the iris lens diaphragm anteriorly. This can result in a shallow anterior chamber and occludable angles. So this anteriorly rotated ciliary body we had seen in the UBM of the first patient. And a word about how to treat UBM. Firstly, to rule out suprachoroidal effusion, medical management with aqueous suppressions if the intraocular pressures are not under control, as were given in our first patient as well. And managing the CCF, whether it is a low flow or a high flow. If it is a low flow, we can always go for carotid compression, and if it is a high flow, whatever the surgical intervention is required. So managing the CCF will decrease the episcleral venous pressure and thus the IOP. PI would only help in cases of pre-existing primary angle closure. And in cases of post-trabeculectomy, like the first patient which we had undergone twice trab. So you should always rule out an overfiltering bleb as a cause of shallow anterior chamber. So in our first patient, I had shown that it had a flat bleb. So overfiltering bleb will have a high bleb and a shallow AC. So you should always rule out an overfiltering bleb also in a case of pre-existent glaucoma surgeries. So that's it from my side. Thank you. These are my acknowledgements.